In the JACC Interventions November issue, a subhead in this particular paper, a call to action, what are we waiting for? The topic is systematic use of Transradial PCI in patients with STEMI. And I am with Professor Mackram Eleid, Professor of Medicine at Mayo Clinic, and Mackram Eleid, who is Assistant Professor at Mayo. Now, why a call to action now?
Well, I think in a nutshell, first of all, thanks for your interest in this, I think, important topic. But I think that the most important thing here is the recognition of the benefits of and safety over femoral using the transradial approach for STEMI. A call to arms, I think, really reflects the fact that we're not really doing this very frequently in the United States, and I think we're a long way behind many other parts of the world, particularly Europe. So this is really an article to put together, some really good trials and some analyses, and to really summarize it and just increase awareness and of this important topic.
What do we need to know in terms of the data as to why we should be thinking more transradially?
Sure. Well, we've known about a relationship between bleeding and mortality in patients with acute coronary syndromes, and there's been several trials, or 2 randomized control trials and now a third, that have shown that transradial PCI appears to be safer with regards to access site bleeding, and that appears to translate to a lower mortality in patients with ST elevation myocardial infarction. Additionally, there's also been some registry studies that have also shown better outcomes in patients with transradial PCI versus transfemoral, particularly in patients with ST elevation myocardial infarction. So lower bleeding rates and lower mortality, 30-day mortality, in-hospital mortality.
I was at the TCT meeting recently, and they had the SAFE PCI trial, which was in women. One of the things they found is that both transfemoral and transradial were really low in terms of bleeding. I think they were expecting about a 7% rate, and they got 3% in transfemoral and a little less than 1% in transradial. It sounds kind of like we're doing better with transfemoral also today. Is that accurate?
Well, certainly I think that we're, much more aware of using bleeding avoidance behavior, and I think that applies as much to radial as it does to the transfemoral. And I think that in terms of the decreased bleeding we've seen with transradial, which I think is very clear from the previous trials, I think that those who are in favor of using transfemoral or have to use transfemoral are taking steps to really minimize the risk of bleeding. I think it's something that we've probably ignored for too long. I mean, certainly in recent years with different technical approaches, different antithrombotic agents, I think we're taking steps in the right direction.
In terms of the logistics, is it as fast to do transradial as it is transfemoral? Because in the setting of STEMI, speed is of the utmost importance.
Oh, definitely. There is a longer door-to-device time in the patients with transradial PCI, and all the studies have shown that. But despite that, there's still a lower mortality in that group of patients. There is about a 4% crossover rate as well from transradial to transfemoral. That we need to keep that in mind. And also keep that in mind when we're doing radial cases that we may need to cross over quickly to transfemoral if we encounter significant difficulty with navigating tortuous arm anatomy.
Is there any indications that would suggest that a patient might be better off transfemoral than transradial?
So that's a good question, and in fact, maybe the very, very elderly, and we're talking about patients in their 80s and above, who may more likely have tortuous vessels. They may be a little bit more difficult to negotiate. So we know that technically that those may be more challenging patients to treat, and we'll use the transradial approach. I would add, though, and the other point to make, though, is on average, and we're talking about experienced radial operators, and we can get back to that later. I'd like to address that. But the increased door-to-device time, it's really only, we're talking about 4 or 5 minutes, but we're talking about the experienced operators. And I think that we probably need to move away from this concept that door-to-balloon time is everything. And as you probably know, recent analyses have shown that despite the fact that door-to-balloon times have come down dramatically, it has had no impact on overall survival. So whilst it's one of these performance metrics that we all want to achieve, I don't think that everyone should be rushing to get the fastest order balloon times, and it's some sort of competition to keep those times low. I think the safety of the patient is the most important thing. And so if it takes you a few more minutes, then sure, that's what we should be doing, particularly if there's enhanced safety.
I mean, it seems like we have kind of peaked out, so the few extra minutes isn't going to come at a great cost. And obviously, if the data shows that it's a lower mortality, then do it. You were talking about the fact that people need to be experienced in order to do this, but you can't get experience unless you start doing it.
Yeah, that's an important point. So, as you know, in the United States, the prevalence of use of transradial, the penetration has been quite low, but it's increasing.
It is.
And the latest data that I've seen from NCDR registry, it's about 1 in 6 patients will have transradial approaches. It's much lower though for STEMI, and in our own institution, it's probably 30 to 40% of patients with STEMI will have a transradial approach, but that's really used among the more experienced operators. I think that you're not going to, if you've only done a few transradials, the next case it should not be a STEMI. And
Sure.
so I think that as we're thinking about training for this, I think you've got to be comfortable with having done lots of angiograms and straightforward PCIs before we move to STEMI. And I think that's just a natural progression in any lab, and I think that makes sense. But as Mac said, you can switch over if you need to, and maybe you have a certain period of time, and if it's clear that there's really difficult anatomy to negotiate, there's always the transfemoral approach. One of the questions comes up, and I'd like to, at least in good spirits, maybe say that this comes from radiophobes. Well, what about if the patient's in shock? And I think, again, the benefits are still there for transradial. There's nothing to stop you putting a balloon pump in if that's what you want to use, or in some other assist device. Although, again, we know the data supporting the use of those routinely is so questionable now. But you can still do a transradial approach, and then you've got the femoral approach for those devices if you need them.
Now, in your paper, although your call to arms is in the setting of STEMI, you actually do address NSTEMI too. What about that situation?
Well, in the NSTEMI population, we have data from the Radial study that doesn't necessarily show a clear survival benefit in patients with radial, transradial versus transfemoral. We do know, though, that access site bleeding is lower. We still need further study of that to really know.
What we also learned out of the SAFE PCI trial was the fact that when the women were asked what they would like to do for their next procedure, the vast majority, like 70%, said radial.
So I think that's a really important point, and we found this with patients who've never even had an angiogram, and already word of mouth, they're coming in for an elective angiogram, and they're insisting, whether it's a man or a woman, who wants it done transradial. And I've had many patients who I know it's going to be technically a difficult case, for a transradial. Maybe they've got multiple grafts or something else I know about them. They've had angiograms before, and they're insisting that we do a transradial. And they say, even if it's going to be more difficult, please do this. And so I don't think we can discount that. I think the patient at the end of the day is the most important person in the equation. We've already talked about safety, but I think that in terms of comfort and what they want, I think that's really important. And in fact, talking about the non-STEMI population, that's a slightly less urgent group of patients. Correct. So they've actually had a few hours to have been educated about, to hear about this, and we have many patients who've come up to the lab, and they're requesting a radial approach. And I can tell you, there's someone who works both in the cath lab and in the CCU. I've looked after, obviously, hundreds, if not thousands, of patients with MIs. The patients who've had a transradial approach, they're so much easier to look after, when they come back to the CCU. I mean, sometimes within an hour or so, they're sitting up in an armchair and, wondering what all the fuss was about.
Right.
And we just don't have to deal with all the bleeding problems. We see some bleeding, of course. Right. It's not all access site. But anyway, patient comfort and what they request, I think, are really important things to consider.
Did we miss anything?
I think, getting back to the question about why is the penetration of this so low in the United States? And I can tell you that, at least in our own institution and talking with other people at other institutions, that we've always questioned how do we teach the fellows, to do this. I mean,
Correct.
It is a steeper learning curve, and so you need to have done 100 or 200 transfemoral before you move to the transradial. And I don't think that's necessarily so. In high volume labs that are almost 100% transradial, that clearly isn't happening. I think it's important to keep in mind you need to be well trained in the transfemoral approach. So I think you've got to learn both. That's really important. And so we found now with our fellows are becoming very skilled, very comfortable with transradial approaches very early on in their training. I think that what we really need to do is we have many senior or very experienced operators who really are entrenched in the transfemoral approach. And I think that, again, I think they could very easily train in the transradial approach, but for whatever reason, there's still this reluctance, to move to that. And I think that, when we get those people doing the transradial approach, they're very skilled operators, and I think that, that'll just prove to themselves and to us that it can be done by everyone.
Well, it's certainly being done by almost everyone overseas in Europe and has been for a while now.
Yeah, in most places, but not 100%.
No.
But
much higher than it is here.
Yeah, and certainly, in fact, our trainees are all clamoring to learn the transradial approach, and I think they recognise that this is going to be important. But as I said, I think it's really important to make sure that we're well trained in transfemoral, because a transradial approach, we talked about a couple of things there, but I mean obviously some really complex interventions where you're using much bigger guide catheters. At the moment, they're better suited for transfemoral approaches, but that's outside the setting of STEMI.
Right. Well, the entire issue of JACC interventions has got a variety of papers on transradial versus transfemoral, and really please take a look at the JACC interventions for November 2013. For Cardiol Source World News, I'm Rick McGuire.